more common cases of idiopathic Crohn's disease, probably there's subtle genetic dysfunction. Maybe you have 1 or 2 genes that are abnormal with a weak effect, but there's probably a profound environmental influence. And to put it all together, if we want to develop a prognostic model of IBD, this is the way I think about it. The inflammation over time leads to the complications, and all of these things affect quality of life and eventually may lead to disability. So genetics has a role in promoting or suppressing inflammation as well as the specific complications. Environment also clearly has probably an equal role. Medical therapy, we hope, intervenes by treating the inflammation or preventing the complication, but also genetics influences the response to medical therapy. That's the field of pharmacogenomics. Medical therapy also can negatively affect quality of life, such as steroids causing a variety of side effects. Surgery can intervene in the complications, but there's practice variation in how we use medical therapy as well as surgery, and that will alter the outcomes. And then finally, there are a variety of psychosocial factors which also affect medical therapy directly, whether a patient accepts medical therapy, and clearly affect quality of life over time. So it's a complicated model that you have to look at if you're going to predict prognosis and outcome. So all of this line of thinking has led me to believe that what we really need is a good population-based prospective inception cohort so that we get unbiased ascertainment of both exposures and outcomes so that we can actually do biobank specimens before disease has really progressed at all. And this will enable us over time to develop predictors of prognosis and also to do etiologic studies, perhaps of environmental exposures. And I came to the conclusion that what we needed was to study a small state. And I realized that there is a small state just south of Massachusetts, Rhode Island, smallest state in the Union. It is small. It's only 37 miles across. It is only 48 miles tall, so you can get anywhere in the state in just an hour. And look at all the water here. Patients stay in the state because they're not going to swim to Long Island for their care. So this, by comparison to Rochester, Minnesota, this is a very small region, very white. And what we see is that Rhode Island, by comparison, is more diverse than Olmsted County, which is overwhelmingly white. It has a 10-fold larger population base, actually, in a relatively small, large population density, relatively small and approachable area. And here's the main thing. There are 78 gastroenterologists at Mayo Clinic. There are 72 in Rhode Island. So it seemed to me that you could approach all these gastroenterologists and try to get them involved in a study to capture these patients over time. And so what we created is OSCAR, the Ocean State Crohn's and Colitis Area Registry. Every good study needs a good acronym and a good logo, and that's ours. How do we do it? The provider, wherever they are in Rhode Island and also in southeastern Massachusetts on the border, if they make a new diagnosis, they present the idea to the patient and ask for permission to be contacted by the study. And then our study personnel contacts the patient, and since it's only 1 hour anywhere in the state, our coordinator visits the patient in their home. And here are the sign stands that are deployed all throughout the state in gastroenterology offices. We have the lighthouse because it's the ocean state. And quite simply, the patient reads the pamphlet, signs their name, tells us how they want to be contacted, and we do the rest. The referring doctor doesn't do anything more other than tell the patient about the study. Then we do a home visit. We collect all sorts of data. We also teach the patient about their new diagnosis, so there's some educational value to the patient. We pay them $100 for their time. And then we abstract data from the medical records. We see them once a year. And we also try to scoop up patients who we might have missed by doing record reviews in these different practices. There are 20 practices to visit. As of December, we had 60 patients enrolled. We had only just started January 1, 2008, and rolled the study across the state. So this is about what we expected, and now we have about 80 patients in the study. We'll measure all sorts of outcomes of interest, quality of life, steroid resistance, complications of disease, hospitalization, surgery, cost of care, and disability. But I think this also has the possibility for studying environmental risk factors. This is from the Manitoba cohort, showing that different postal codes have significantly different rates of inflammatory bowel disease, suggesting different environmental influences. And I think we could do the same thing in Rhode Island, where we have a highly urban area and also fairly rural areas distributed through the state. We could study all sorts of environmental risk factors, but you'll realize it's much more difficult to study the environment around you, which is so complicated, as opposed to studying genetics, which is unchangeable for a given individual. So there's a growing interest in this field in early intervention with biologics. There is the potential to improve the natural history. The role of concomitant immune modulation is really quite uncertain at this point, and I think patient selection is going to be the key to the risk-benefit equation for an individual patient. We still need better therapeutics. I showed you that there is still an unmet need here for many patients who don't respond to anti-TNFs. There is a growing need, I think, for epidemiologic studies like OSCAR to develop accurate prognostic models and also to get to the next frontier of discovery, which is environmental risk factors. So I hope you found this of interest and useful to you, and I thank you for your attention.
So, Bruce, suppose one could identify some good prognostic factors. Is there any hope that people who have poor prognostic indicators might be better treated by the anti-TNF agents? I mean, it could be that it's the people who are better off. I mean, is there any evidence one way or the other? In other words, the prognostic factors tell me who's going to be worse off no matter what, but they don't tell me particularly how to treat people.
Right. You're asking really, if you have a worse prognosis, are you going to respond equally well or at least as well as the patients who don't have that worse prognosis? Right. And I have to say that we can't really answer that at this moment. But at least on the risk side of things, at least it's a worthwhile risk if you're going to use a more aggressive intervention to try that with those patients. But it's a perfectly valid point. The only thing I can say is that we do show that these agents are effective in patients who already have established complicated disease, and therefore I think that it would be effective, and probably, I've shown you some data that probably earlier intervention for most patients is going to be more effective. It's just a question of, is it worth that added risk?
It's concerning that the treat data showed that stenosis, stricture, or obstruction was not decreased by use of anti-TNF agents. And I wonder if, to some extent, the horse is already out of the barn by the time we treat people. Because Walter Reinish's data, I don't know if you've seen, that if you start immunomodulators after the first surgery, they're very effective at preventing a second surgery compared to people who don't get immunomodulators.
Right. And you can look at that surgery as resetting the clock to time 0. So it's another valid question. Many patients, when they present, already have complicated disease. They already have a stricture or a fistula. And it may simply be too late for those patients. That's quite possible.
Or at least for that segment of bowel.
That segment, right.
I wanted to ask on the narcotics issue. I don't know what you think of Jill Smith's data from Penn State, where she's shown that narcotics and activation of mu-opioid receptors increases inflammation, and that naltrexone may actually be beneficial. Do you think that might explain the finding of narcotics in the treat database?
Yeah, I'm aware of those data. I'm looking for replication of the data. It's an interesting pathway, an interesting mechanism. Yeah, I mean, it's quite possible that it is a direct effect rather than just a marker of something else.